Our next speaker will be Dr. Victor Morell. He's the Eugene Weiner Endowed Professor and Chair of Pediatric Cardiothoracic Surgery, Surgeon-in-Chief here at UPMC, the Executive Director of our UPMC Heart and Vascular Institute, and the Co-Director of the HVI at Children's. Dr. Morell, he'll be talking about the novel alternatives to transplant biventricular and 1.5 conversion.
Thank you. Thank you, Matt. Thanks, everybody, for hanging around. I know it's been a long day, and hopefully I won't make it any longer than it has to be. I have no disclosures. You know, I thought that this was somewhat of a very difficult topic because I'm not sure that we have really novel techniques to transplantation in single ventricles, but I think we have some ideas. We have to assume, as has been described by many different people in this panel, that every single patient who has a single ventricle physiology will likely or has a real chance of ending up in a transplant center for transplantation. Cardiac liver, I mean. So I think when I think about this specific talk, that when we look at viable alternatives for transplantation, I'm really looking for viable alternatives to single ventricle physiology because that's really the question, and that's what I think my talk will be about. And also, in those few alternatives, are the outcomes any better than transplantation? So this is a meta-analysis on which I kind of like the title of it. Said meta-analysis of the effectiveness of heart transplantation in patients with a failing Fontan. So the effectiveness is kind of, how effective is transplant on these patients? And this is meta-analysis of many different, and you can see mortality, it varies throughout. Obviously, different centers have different expertise, and I think, unfortunately, for transplantation, we see that outcomes can be affected by that. But let's assume that the 1-year survival for a transplant on a failing Fontan is about 80%. Now we'll go with that number. So when should we consider alternatives for the Fontan-Kreutzer palliation? And really the answer is always. Unfortunately, most of the time we have no other option, but we always think about the possibilities of doing something different. And it's always difficult to consider another option as surgeons, I have to tell you, because the Fontan-Kreutzer procedures become such a standard, simple, straightforward, extremely low mortality procedure that at times, myself, I say, why would I expose this beautiful child to this complex of an operation, maybe get to a biventricular repair, maybe, at maybe, I don't know what kind of cost, with a higher mortality, maybe more reoperations, when I can certainly guarantee a family that comes for a Fontan that the patient's going to be fine. I mean, the mortality for the Fontan-Kreutzer nowadays is almost 0%, honestly. So it's somewhat of even a moral discussion as a surgeon, as a team, say, what are we going to do with this patient, So anyway, the group from Boston truly have pioneered the concept of can we grow a ventricle? Which it's been around not for a little while. First paper here by Imani in 2012, looking at the recruitment, what they call stage left ventricular recruitment after single ventricle palliation. And it's truly an interesting study. They looked at 34 patients in which they're taking through the single ventricle stages, Norwood, Glenn, and Fontan, but they're also doing other surgeries to different structures that we'll discuss, and compare them to patients who are going through the same process, but they're just going through the standard, Norwood, Glenn, Fontan. And you can see in the left heart rehabilitation group, they're doing, stage 1, but at that time they might be doing EFE resection, they might be doing a mitral or aortic valvuloplasty, ASD restriction. You can see in stage 2, they're readdressing some of those issues. Stage 3, they're readdressing some of those issues. And they're comparing this group to patients who just had a Norwood, Glenn, Fontan with nothing else, okay? And then we look at what happens to those ventricles. And they show that the left ventricular and diastolic volume grows, so that ventricle seems to be bigger. The length of the ventricle is bigger. Compared, this is the patients who didn't have the valvuloplasty or anything else, they just had Norwood, Fontan, and these are the patients that had the LV rehabilitation. The mitral grew. So you can argue that this is an interesting concept, that maybe we can grow a left ventricle on the mitral valve and the aortic valve, but only 13 patients out of the 34 that was in the rehabilitation group ended up getting a biventricular repair, and the outcomes are somewhat unclear yet, so we don't know what's really happened. This was followed by a more recent paper in 2021 from the same group that are looking at biventricular conversion after Fontan, and this is a preliminary experience. And again, they agree that even patients with well-functioning Fontan circulation, long-term failure is inevitable. So again, we have to look for other options. So they had a total of 23 patients, 17 that had a primary biventricular conversion, and 6 patients that had a stage biventricular conversion. So they had a Fontan. Some of them went from Fontan, 17 of them Fontan, to a biventricular conversion, and 6 that they had stage conversion, just like the previous ones I just showed. When you look at the diagnosis, clearly it makes sense that patients with hypoplastic left heart syndrome who were Fontans at that time, they needed a stage conversion as opposed to a primary conversion. And a lot of the patients with the primary biventricular conversion were patients that had some type of heterotaxy, TGA, DORV, and all their diagnosis, only one was under the diagnosis of hypoplastic left heart syndrome. When you compare the pre-op hemodynamics of these patients, essentially was very similar. When you look at the end diastolic volume and systolic volume, the patients with the primary biventricular conversions tended to have slightly bigger, and I would argue almost normal size ventricles compared to the patients with who had stage palliation. The staging, the recruitment of those 6 patients asked in that first study, included fenestration of the ASD, atrial and mitral valvuloplasty, resection of EFE, so again, very similar. When we look at the overall survival, of the whole 23 patients here, you can see that the early mortality and the mean follow-up on these patients is only 1 year. Okay, so we don't really have any long follow-up on these patients. It's just 1 year, but at 1 year you can see the overall mortality or the overall survival. I think it's just south of 80%. Reintervention-free survival, as you can see, is quite poor. When you look at reoperations and caths, in these patients, they're significant. A lot of patients need reoperations. A lot of patients need cardiac catheterizations. Interesting, when you look at the survival of patients that came in for just elective, so they were not considered to be failing Fontans, the survival is quite good. So you have a patient who's otherwise doing fine, who has a Fontan, that comes over and you say, well, can I turn this patient to a BiV repair? Those patients in which you can do it apparently do well. But if you try to convert somebody who's coming with a failing Fontan, the outcomes are not as good. From the Boston group, there's a significant learning curve to this biventricular conversion. And obviously, as we can imagine, these are complex operations, and I think we can argue all day about growing hypoplastic left ventricle. If it's, can you really make it a real ventricle? Is it, even though it's bigger, is it really normal? And certainly, but there's a learning curve to doing these operations. They concluded, at the present, it is unclear whether this treatment strategy is superior to conventional single ventricle palliation or preferable to transplantations in patients with a failing Fontan. Okay, so even though it's an option, it's really unclear that it's any better than just going ahead and doing a transplant on those patients who have a failing Fontan. This, I think, is a very interesting paper, and some that specifically I haven't really thought much of. And now every time I see a patient that could be a candidate for this, I consider it, which is a concept of ventricular switch. Basically, in patients that have 2 ventricles or maybe have 1.5 ventricles, instead of just saying, well, the LV has to be the systemic ventricle, maybe we just keep the RV as a systemic ventricle and do arterial switch. And that is a great concept, and maybe not applicable to 1,000 patients, but it might be applicable for a few patients that we see every day in our clinic. And for this specific, they had 3-dimensional models they thought that were critical. And I have to say, the more we use 3-dimensional models for complex patients, complex transpose, for example, it is very useful. It's a tremendous complement to what we do every day. They only presented 5 patients. There's only 5 patients here from different centers. They all had basically heterotaxy, as you would imagine. And 4 of the 5 were basically done as a salvage. These patients were failing in some single ventricle stage, So, and if you look at the operations they ended up doing on the patients, included, septation of AV valves, repair of partial anomalous pulmonary venous return, atrial conversion. So you have to do atrial switches because you're going to put you have to redo the way the venous system works inside the heart. And you have to put an LV to PA conduit because the LV is becoming now the subpulmonic ventricle. Okay, interesting concept. I think that this is something that we might see more in the future. I also wanted to just point out that I know Mark Rutherford in Indianapolis and his colleagues, he's been working now for quite a few years on developing a Fontan pump, which theoretically could become a ventricle. And this is basically, you have this pump here, somewhat spins in the middle of the intersection between the IVC, SVC, RPA, LPA. And the concept is that it augments the flow through the SVC, IVC, and through the RPA and LPA. And at least in the lab, you can see in a mock loop, this the baseline pressures in the cava was 17, on the PAs was 14, so you have a higher pressure in the cava than you have in the PA, but when you use this pump and start getting at higher reps, you drop the pressure in the cava and you increase the pressure in the PAs, which is really what happens in our heart. Our ventricle increases our pressure in the PAs. So this is an interesting concept still. A lab experiment. We have, it's never tried in humans, but maybe one of these days it will. And I just want to just describe a recent patient we had, came as a consult from another center, 10-year-old boy with heterotaxy, dextrocardia, DORV with pulmonary atresia, had severe AV valve regurgitation, right-sided, had bilateral Glenn's and a Fontan-Kreutzer procedure. Had plastic bronchitis for 2 years and failed lymphatic intervention. And on presentation was coughing, casts daily. Had a MR, showed dextrocardia, patent bilateral bidirectional glands, unobstructed Fontan. Left ventricle was anterior and inferior, and leftward, where the right ventricle was posterior and superior and more to the right, and the aorta arises from the right ventricle. The right ventricle was mildly hypoplastic with good function, and the left ventricle had good function too. It was basically from the MR, you can see the RV here, slightly hypoplastic, the LV here, aorta was sitting right there. Had a right-sided IVC to PA, had bilateral bidirectional glands. You really can't see the left, but it was there. So we presented in conference and thought that this was maybe a candidate that we can, we agreed that we'll take to the OR and try to convert into a biventricular repair. So we did a 1.25 ventricle repair, and we repaired the first thing. We repaired the tricuspid valve. We patch closed the VSD. It was more of a Rastelli type funneling of the LV into the aorta. We had an RV to PA conduit, Fontan and left glen takedown, and I left the right glen simply because anatomically I couldn't figure out a way to reconnect it. The aorta was in the middle, the RV to PA conduit was in the middle, and there was really no other way I can get that right glen into the heart, into the atrium. The post-op TE showed normal ventricular function, trivial tricuspid regurgitation, and no stenosis anywhere. This is a post-op from an MRI reconstruction. You can see here the aorta connected to the LV. You can see the RV here. The conduit kind of sat to the right and looped around. So when I did the operation, I initially had to transect the aorta in order to take down the glen. The left glen is here, reconnected to the top of the right atrium. You can see the right glen here who stayed connected to the RPA. We were able to disconnect the Fontan conduit and connected it to the right atrium. And the patient did quite well. He had post-op cath that showed great hemodynamics. So just some final thoughts. We have a limited number of options to transplantation in patients with failing single ventricle physiology. Biventricular conversion is really rare and often plagued with complications. We still have no proof that it provides better outcomes. Stage recruitment of the LV is an interesting concept. We still have minimal data. Ventricular switch concept needs to be considered in some of the patients that we see, and I do think that certainly it should be in an armamentarium. And there are certainly patients with complex anatomy, probably a lot of patients with heterotaxy, that are reasonable candidates for biventricular conversion. Thank you so much.